My brother had his first seizure on Christmas morning due to a brain tumor. We were all devastated and shocked. After a new diagnosis of epilepsy, that is probably what is happening to you. Take time to overcome your emotion, and after a few days, start to think of epilepsy as a disorder, which gives us a good chance to lead a very productive and healthy life. Epilepsy is the third most common neurological disorder in the United States. It is equal in prevalence to cerebral palsy, multiple sclerosis, and Parkinson's disease combined. And approximately 2.5 million Americans are affected by epilepsy. It is not a single entity, but a family of more than 40 syndromes. Although people of all ages can be affected by epilepsy, the very young, under 2, and the elderly are the most affected. In the United States, epilepsy currently affects more than 326,000 children under the age of 15, and more than 90,000 of them have severe seizures that cannot be adequately treated. There is an extremely high burden of illness associated with epilepsy. The mortality rate among people with epilepsy is 2 to 3 times higher than that of the general population. Optimal seizure control can reduce the risk of epilepsy-related mortality, decrease morbidity, and greatly improve the quality of life.
We all operate by means of electrical impulses. The brain sends out signals that tell other parts of the body what to do, like picking up the telephone or when to feel hunger. Every thought, action, or feeling is transmitted by these impulses charging and discharging. If one of these impulses fails to turn off, the result is a seizure. How the person is affected depends on where the impulse is located in the brain. For instance, a person may experience involuntary movements, loss of balance, uncontrolled eye movements, or speech may become garbled, and awareness may be affected. Seizure episodes can last a few seconds or a few minutes. The person will usually not remember what has happened. All that remains is a period of weakness or tiredness. The reactions of those present are often more damaging than the seizure itself.
Today we're going to talk about types of seizures and seizure first aid. The two topics go together because you have to know really what kind of seizure someone's having in order to deliver the right kind of first aid. In order to do that, we need to talk about some fundamental principles or bases on which we decide what kind of seizures are occurring or what someone's having during a seizure. Seizures are fundamentally divided into those that are focal, that is, begin in one part of the brain. They can spread, but begin in one part. Or generalized seizures, in which the electrical storm begins throughout the brain all at once. The kind of seizure that most people are familiar with is a generalized tonic-clonic seizure. In this kind of seizure, the electrical storm starts everywhere at once. The patient becomes stiff all over, rigid. If they're standing, they fall over, typically backwards, with unprotected falling, may even hurt themselves. And after they fall to the ground, then they have jerking all over, all 4 extremities, so their arms and legs jerk rhythmically all together. Fortunately, it only lasts a few minutes, typically less than 3 minutes. And during that time, the patient's entirely unconscious because their entire brain's busy having a seizure. In addition to falling down and jerking all over, sometimes people are incontinent, that is, they lose control of their bladder, they wet on themselves. They sometimes are injured when they fall to the ground, or sometimes have contractions so strong that it may actually break a bone. Fortunately, that's uncommon, but it can occur. Seizure first aid for this kind of seizure is what we usually think of when we think of seizure first aid, and it's why I'm beginning there. In this kind of seizure, the most important thing you can imagine is if you see someone starting to have one, is to catch them before they fall and lower them to the ground. Once you lower them to the ground, it's important to protect them from injury. And what that means is that to not lower them onto any sharp objects or move any sharp objects out of the way. Also, once they're laying on the ground, they're likely to have this rhythmic jerking. And they may even be bouncing their head or pounding their head on something. So it's important, if you can, to put something between their head and the ground or whatever they might be hitting. So if you're wearing a jacket or if you have any other soft surface to put between the patient's head and the ground. It's also important to recognize that during this time, the patient's often rubbing very vigorously against whatever they're near, like the ground or carpet, And so it's useful to move them away from anything they might be rubbing against. If they have on a tight shirt or a tight collar, it's important to loosen their collar so that they're able to breathe more easily. In most situations that isn't necessary, but sometimes it is. If you're able, and the situation is right, it's a good idea to roll them onto their side. And the reason for that is because during a seizure, people often salivate a huge amount. Foam seems to come from their mouth, and they may even bite their tongue, and blood may be even coming from their mouth. By rolling them onto their side, the blood or foam, or if they throw up, will come out their mouth and not down into their lungs. You might have heard you should put something in their mouth so that they wouldn't swallow their tongue, but that in fact is not true. You should never put anything in the mouth of someone who's seizing like that. The reason is because, first of all, your tongue is attached in your mouth, so you certainly can't swallow your tongue. But it is true that sometimes your tongue, you might think, could obstruct the airway, could get in the way of breathing. But simply rolling them onto their side will help the tongue to fall out of the way and for them to breathe. During that first part of the seizure, called the tonic phase, people are stiff all over, and during that time they won't breathe because all their muscles are contracted. But that phase only lasts just a few seconds. So usually, by the time you recognize it's a seizure, they've already progressed onto the clonic phase. That's the jerking part of the seizure. And during the jerking part, not only will they be breathing, but often they'll be breathing a particular kind of guttural or deep kind of respiration, sort of a sound. So you know they're moving air, so you know they're breathing. It may not be very effective, but they're breathing. As soon as that kind of seizure is over, patients have a huge relaxation, as though they're dead to the world. And often when they breathe, it's a deep kind of respiration. It's a and the reason they're like that is because their whole brain is exhausted. So they breathe this slow, deep breathing, and they're entirely unconscious typically. They'll slowly recover over the course of 10, 15, 30 minutes. Sometimes might take all the way to an hour to come entirely back to themselves. After they first wake up, they may be confused, but gradually they'll return to normal. So first of all, in terms of seizure safety, it's important to recognize this typical sequence of events. Under normal circumstances, when someone has a single seizure who's known to have epilepsy and known to have this kind of seizure, in which they haven't hurt themselves, and it's a typical seizure, you can simply wait until the seizure's over, and then tell the person they've had it, keep them safe, and help them go on about their day. Usually you would not need to call the rescue squad. However, there are certain situations if you witness a seizure like that, if anything at all is unusual about it. So first of all, if it's the first time someone's had a seizure, they need medical evaluation. Second, if they happen to be pregnant. Third, if they have anything else wrong with them, other important medical conditions like a brain infection, or they're known to have other problems like certain kinds of cancer. It's also important to recognize that when a seizure like that goes on for more than about 5 minutes, it's unlikely to stop on its own, and it may go on to be as much as 30 minutes or an hour or just keep going. So if a seizure goes on for more than about 5 minutes, it's important to call the rescue squad. The second kind of seizure we're going to talk about is also a generalized kind of seizure, and it's a myoclonic seizure in which someone has a brief jerk. Often it's of the arms, like this. Sometimes it involves the face or the eyes. Sometimes it's very subtle, just involves one hand or one leg. When that happens, typically others might not even notice, and it doesn't really cause a medical problem that requires first aid. But there are a couple of situations in which you should consider first aid for myoclonic seizures. First of all, although it's not exactly first aid, it's a problem with seizures in that someone may drop whatever they have in their hand. And that can be a problem, or worse yet, it might fly out of their hands. So if they're holding a knife, that could be a danger. That's almost never a problem, but something to consider. The one time that myoclonic seizures can be important is sometimes they cause people to have myoclonus of their whole trunk, and they're thrown to the ground. And when they're thrown to the ground, then they could have injury. In that case, in which myoclonic seizures occur like that, first aid usually isn't necessary as part of the seizure because the seizure's over almost as soon as it happens. Of course, if someone's hurt themselves, then they'll require first aid for hurting themselves in whatever way they might be injured. There's another type of important generalized seizure that's kind of the opposite of that. It's called an atonic seizure, or drop attacks. And in drop attacks or atonic seizures, people suddenly fall to the ground loose and limp. So instead of getting stiff, they just as though they fainted, they fall to the ground. And that, you can imagine, could really result in injury if you have unprotected falling and crumple to the ground. Unlike a generalized tonic-clonic seizure, when someone might fall over like a tree, in this case they crumple to the ground. So they may hit something on the way down, like their forehead on the desk or a windowsill. And the final type of generalized seizure we're going to talk about is an absent seizure, what used to be called a petit mal seizure. And it involves staring, simply staring unresponsiveness. It most often happens in children, but even if it begins in childhood, sometimes it persists into adulthood, or adults can have it too. The good thing about this kind of seizure, it usually consists only of just staring. Occasionally there may be a bit of hand rubbing or swallowing or making noises, but most often it's just staring. It's usually very brief, on the order of just a few seconds. So someone who has one just stops for a moment, just like that. Then they go on about what they're doing, and it's not a problem. There are a few kinds of absent seizures in which people may fall to the ground, sometimes in children particularly, who have other types of problems like developmental delay or cognitive impairments, who have a number of different kinds of seizures. During their staring absent seizure, they may have an atypical absent seizure in which they actually kind of ratchet down to the ground, in which they lose tone. So in those kinds of cases, you have to be sure they don't fall and hurt themselves. But in general, absent seizures aren't a problem. So what we've been talking about are generalized seizures, seizures that involve all of the brain at once. But the electrical storm of a seizure can also begin in just one small part of the brain, or one focus. That is, these are focal seizures. And focal seizures are fundamentally divided into simple partial seizures and complex partial seizures. The terminology doesn't really matter, but what's important is that in simple partial seizures, or highly focal seizures, it involves just one small spot in the brain. And because of that, as you can imagine, it just causes very specific symptoms in just one part of the body. So for example, when focal seizures begin in the right motor cortex, that's one small area in the brain on the right, which affects the left side of the body, it might just involve jerking, say, of the left hand. If it involves a sensory spot in the brain on the right, it might just involve sensation abnormalities in the left hand. For these type of seizures, first aid usually isn't necessary, and people are able to talk and understand during the seizure. They're otherwise perfectly fine, and they can point out the problem. So first aid's not very much of a concern under normal circumstances. Complex partial seizures, or what are now called dyscognitive seizures, is a very recent terminology. The importance about that kind of seizure is that it involves a part of the brain that involves awareness or controls awareness. And because of that, people are unaware during this kind of seizure. During this kind of seizure, they may stare and be unaware, and that may be all they do. But more often, if it lasts long enough, it'll go on to involve other symptoms, sometimes hand wringing. They may crush what they're holding in their hand. Sometimes they may make noises like lip smacking or swallowing loudly. During this time when they're staring and they're unresponsive, that is, you can speak to them, but they can't answer back and are unaware of what's going on, they typically are standing still. And that's fine, and there's no seizure first aid necessary. You just need to stay with them and make sure that nothing else happens. Because the other things that can happen is it can progress on to cause some posturing. And during posturing, it affects the arm and the leg, then someone could fall during the posturing. And that seizure that begins in one small spot in the brain could spread to the whole brain. So you can have a focal seizure that then generalizes. When it does, it then acts just like a generalized tonic-clonic seizure that we've talked about so far. So it may begin with just staring, and then some hand rubbing, and maybe some lip smacking. And then it may progress as it involves more and more of the brain to cause some stiffening. As it causes stiffening, then it could spread to involve the whole body and have a whole generalized tonic-clonic seizure. In that case, normal generalized tonic-clonic seizure first aid is necessary. There are a couple of other special seizure types to talk about that are not exactly seizure types, but seizures occurring in a special circumstance. One of them is febrile seizures. Febrile seizures are seizures that are precipitated or caused by fever occurring in children, typically in children around age 5 or younger. In this case, the child who's otherwise healthy and fine has a fever for some typically incidental reason, like a cold or infection. And then as the fever is going up or as the fever is coming down, then the child will have a generalized tonic-clonic seizure, so a whole body shaking episode. This most often happens as a single seizure. Now you can imagine that when you see this happen in your child, you're very concerned. Hopefully rush them to the hospital because it could be caused by something else. But when it's determined that it's just a febrile seizure, the good news is that's unlikely to progress on to cause epilepsy or recurrent seizures later in life. It's also pretty common, surprisingly common. About 5%, so that's 1 in 20 children will have a febrile seizure. Like I said, most often it doesn't go on to cause epilepsy. The time when we want to consider febrile seizures more closely to see if they're due to something else or something besides febrile seizures, if they're very long, they go on for more than 30 minutes, for instance. If instead of being generalized tonic-clonic seizures, they're focal seizures, and of course we would look for something focal that could be wrong in the brain. Or if they happen in someone who has other medical problems or other neurological problems, we might wonder if it's a consequence of that, and that would require further testing, for instance. Catamenial seizures are seizures occurring in women around their menstrual period. Among all women with epilepsy, if you simply ask them when are they most likely to have a seizure, about 30% or more, depending on the kind of seizures they have, will say that they're most likely to have them around their menstrual period. If they have them only around their menstrual period, so no seizures any other time of month, then at the time of their menstrual period have seizures and not at other times, and that's called catamenial seizures or catamenial epilepsy. So what we've talked about is generalized seizures that occur everywhere. We've talked about focal seizures that begin in just one part of the brain. Talked about status epilepticus, which is a medical emergency, one seizure that doesn't look like it's going to stop on its own and occur and last more than 5 minutes. The other thing to note about status epilepticus is that sometimes someone can have one seizure and then a second seizure, and if they don't wake up in between, we don't really know that they're not continuing to have seizure activity in their brain. So if you have two seizures less than 30 minutes apart, we'd also call that status epilepticus, which I should have mentioned before. And finally, we talked about seizures in some special circumstances, that is, febrile seizures and catamenial seizures.
EMTs, police officers, school nurses, and many other professionals benefit by learning about epilepsy. We have excellent trainers at the Epilepsy Foundation in Virginia, and many neurologists with a special interest in epilepsy are involved. So please contact us via www.efva.org.
With epilepsy, the first diagnosis can be terrifying. At least it was for us. Epilepsy can mean so many different things, and a lot of people just don't have a lot of information about epilepsy. That's what inspired the idea for this DVD. As newly diagnosed patients, we needed something to give us an overview of the many facets of epilepsy and a place to start as we take control of it. First, you're not alone. 1 in every 26 people has epilepsy. It is the third most common neurological disorder after Alzheimer's and strokes. The first 6 months will be challenging with all the tests, understanding the diagnosis, and understanding the adjustments to your daily life. Some things will change and some will stay the same. It's important that the family supports each other, not just the person with epilepsy. Do not be so focused on the child with epilepsy that your other children do not get the attention they need. Everyone in the family should be involved to keep your daily lives as normal as possible. For your newly diagnosed child, be an advocate for him. Teach your child how to advocate for himself. Make sure your extended family, caregivers, teachers, friends are informed and know what to do in the event of a seizure. Especially at school, where your child spends a large part of each day, make sure the teachers understand your child's diagnosis, what to watch for, and how to provide first aid. They can provide observations and support that will help you get control, and your child will feel safer and more confident. So will you. You should have a great relationship with your doctor. An epileptologist is an epilepsy specialist. They will understand when you take notes during your appointments and will encourage you to ask questions. Feel free to take someone with you to the appointment because 2 heads truly are better than one when listening to new information. During the doctor's visit, write down the epilepsy syndrome, what to expect, and what your next step is. Find out about medications and their common side effects. Because epilepsy is their specialty, epileptologists are the best informed about the medications available. Medications take 2 to 3 weeks, sometimes a month, to reach a therapeutic level and start to work. If after that time the medication is not controlling seizures or has too many side effects, the doctor will want you to call. It often takes several trials to find the right medication or combination of medications to control the seizures with minimal side effects. Between conversations with your doctor, it's important to keep a daily journal and be meticulous. This will help you get control. Write down when your child sleeps, what he eats, physical activity, how they feel, changes in medication, and of course information about your child's seizures. What were they doing at the time of the seizure? Had they just awakened? Did they fall, cry out, stiffen, convulse? What part of the body was first affected? Was there any bladder or bowel control loss? Did their skin turn blue? Were they flushed? Could they speak or respond to questions? Taking control means all this: keeping a journal, asking lots of questions, having a great relationship with your doctor, and gathering your support team. That support team is made up of family, friends, caregivers, teachers, and of course, the Epilepsy Foundation of Virginia. The EFVA is a great place to start because it has an abundance of information about everything about epilepsy. There's also tons of information on their website, efva.org. Take advantage of all this information that was gathered by experts. The most essential component of the EFVA, I think, is their people. The people at the office, the network of volunteers, the support groups are there to help you and your family. We have been in your shoes and know exactly how you feel. We know your questions, your concerns, your worries. We can help. Call us.
Well, first of all, epilepsy in adolescence is one of the most common neurologic problems in that age group. And it's tough to be a teenager to begin with, and I think I certainly can think back to my teenage years, and teenagers are battling a lot. They're learning who they are. There's other social challenges that come up, such as new friendships, dating, dealing with driving, drugs and alcohol, and all those things come up, and they're complicated in teens who have epilepsy. Teens with chronic disease in general certainly is more complicated in patients with epilepsy. So I felt like there was a specific need in my teens to really be able to address those issues. And the issues are very different than what kids have who are dealing with epilepsy and what adults have. So I think it's important to think about teens as a distinct group. So when a teen is first diagnosed with epilepsy, I think the most important thing is to educate the teen on what epilepsy is. Some of the teens I see are diagnosed as kids, and when you're diagnosed early on, often a lot of the educational information is aimed at the parents. So the child never really understands their diagnosis. I also see a different subset of groups of kids that are diagnosed in adolescence. And again, it's important for them to understand what their disease is, what epilepsy is. Some of the toughest issues that adolescents face are typical adolescent type issues. Issues like driving, dating, new relationships, drugs and drinking. And teens without epilepsy battle those, but it becomes tougher when you have a condition like epilepsy.
You should have a normal life in all aspects of your life. And this is why, for example, through our support groups, when they ask about dating, there is no rule for that, but we always said, listen, you have to do something very, very light, something nice, like, for example, go to the movies, or go to have a cup of tea, have a nice walk at the park, you can go to a museum, etc. And do not talk about epilepsy. Probably when you get the third date, you can start talking in a very normal way about this issue, because epilepsy is a disorder that can happen to anybody.
So one of the things I try to do is really to have an open dialogue, and an open dialogue very early on between the teenager and myself as an epileptologist, and also with the parents. Not only is it important for the teen to understand the issues with having epilepsy and driving and others, such typical adolescent concerns, but it's also important for the parent to understand as well, and for the parents to understand the risks.
But in a very simple way, they can drive. I mean, there is no problem with that. They should be work with their doctor and the DMV about their seizures. Most of our clients drive.
The teenager learns to manage their medicines themselves, and the parents need to learn to take a step back. And that's a really tough process for the teen and really hard for the parent as well.
We organize every year a contest called Use a Helmet, Prevent Epilepsy. It is addressed to 4th graders in every school in the Commonwealth of Virginia. and they are supposed to produce a drawing with the theme, Use a Helmet, Prevent Epilepsy. In November, in Charlottesville, where we have our main office, there is a panel, a committee, that will choose 12 drawings that will be the winners. Those winners, they are invited in January to the General Assembly in Richmond, where they are going to receive their awards for these drawings, and the awards will be given by the Lieutenant Governor Dr. Ralph Northam and Delegate John Obana. But if you see our programs, many of them are addressed to the general population. With the Use a Helmet, Prevent Epilepsy, and they understand very well, and at the same time, to tell them that a person with epilepsy is a normal person. All the studies done so far, it required $0 in order to hire a person with epilepsy. The only thing that the employer needs to do is to eventually call some of us, and we will give a training to the other employees what to do in case the person will have a seizure. And this costs nothing to the employer, to the person with epilepsy, to anybody. So at any level in society, we try to promote the idea of normalcy, that they are like everybody else.
A 2013 survey showed that approximately 56% of patients with epilepsy completed high school compared to 75% of the general population. Only 15% went on to finish college compared to the national average of 55% for the general population. With this in mind, we believe there's so much more we need to do for our young people with epilepsy. The IDEA, the Individuals with Disabilities Education Act, is the main law that governs special education for children with disabilities. It sets out a framework for identifying children with disabilities that impact learning, developing an individualized education program, the placement of children into special education, and review of those placements on a regular basis. Students with epilepsy may not need formal special education, but they can benefit from accommodations such as the administration of seizure medications or extra time for tests or reduced workloads. For these students, it would be appropriate to have a Section 504 plan, which is an agreement that sets out reasonable accommodations for students with conditions like epilepsy to ensure they have the same access to education as other children. Children with epilepsy may face a number of scholastic and behavioral problems. If a child's teacher reacts appropriately and positively, their classmates will also react in a similar appropriately and positive fashion. A child's slow responses or sedation may lead to unpopularity or criticism from their classmates. They may feel as though no one likes them, or that while nothing is said, when classmates choose their partners, they are never actually chosen. In an in-depth study with 24 adolescents with epilepsy, 71% reported prejudicial behavior, especially bullying and teasing in secondary school. The study showed that friends were generally those who knew about epilepsy and understood why a child behaved the way they did. Here are some suggestions that may be helpful to students with epilepsy or other disabilities. You may want to consider a change in your child's schedule. Many times students do better if they can start and finish later in the day, for example, starting at 10 a.m. instead of 8 a.m. and then finishing 2 hours later. Contact your child's teachers and explain the need for more time to complete examinations. Some students have benefited from being allowed to record lessons so that they can review them later in the day. In some cases, online classes may also relieve stress. Memory exercises and assistive devices can be important for patients with epilepsy, and those devices are available through the EFVA. A child with epilepsy should be encouraged to participate in sports and other social activities. Using a buddy system and having your child's friends aware of their epilepsy can also be extremely important. With proper accommodations at home, at school, and on the playground, a child with epilepsy can be accepted, happy, and successful, and can become an appreciated member of their community.
When entering the job market, decide what sort of job you want. Identify the qualifications you need and determine if you could safely perform the job. Evaluate your level of seizure control and consider jobs that allow you to work at your own pace with flexible hours or from home. EFVA's online booklet, Epilepsy and Employment, will help you here. It can be difficult to decide what and when to tell a potential employer. There are many factors to consider. The nature and extent of disclosure will probably depend upon your particular circumstances. Remember, there are laws governing what an employer can ask about disabilities in a job interview. If you decide to talk about your epilepsy during the job interview, think carefully about questions that might come up and how you will answer them. Remember that the employer's concern is job performance and safety. Show the employer that you are a normal and capable person. Focus first on your qualifications for the job. Establish the fact that you can do the work and do it well. Then talk about epilepsy. Stress the fact that Department of Labor studies have shown that workers with epilepsy have better than average safety records. Explain how you cope with the possibility of having a seizure. Facts are the best way to overcome a potential employer's fear. Explain the facts about your seizures, whether they come at certain times of day, how long they last, how long it takes to recover from them, and whether or not you have any warning. Explain how you would prevent them from interfering with your work. Also say that there are thousands of people with epilepsy working in almost every type of job. In fact, their epilepsy may give them a very high motivation to do the job well to prove their ability. Also, having a buddy at work who knows what to do when you have a seizure will help as well.
So I'm going to give you some pearls of wisdom when you're diagnosed with epilepsy that you should know. One is I'm going to say keep calm and learn your resources. That's going to be the first thing. And we'll come back to resources at the end. But I want you to know that it's not the end of the world, and there's some things that you can do in your home to be able to help you with safety. So let's talk about cooking. And one of the things that we recommend is that you use your microwave. Cooking with the microwave is great. That same baked potato that you would have that took a couple of hours will take a few minutes in the microwave. The next thing you want to do is you want to make sure that your house is kind of safe. And a good example of that would be like your tables or things in your house that have sharp edges. You want to pad them. Just put something soft, because the one thing, again, you want to make sure that you're safe and that if you fall to the ground, you don't hit your head, or that if you're on the table is there, you don't bump your head, and you want to be safe.
So having epilepsy does not preclude you from having a normal physical relationship with a partner. Nothing that you're going to be able to do during the course of that relationship will make you more prone to have a seizure. Could a seizure happen while you're in the act? Perhaps. A seizure could happen while you're in the middle of eating dinner. That's the nature of the beast. You never know when a seizure is going to occur.
My goal here in the area is that I go around to different neurologist offices and I talk to them about different treatment options for seizures. And if you're newly diagnosed with epilepsy, the first treatment option would be medication. Your neurologist will start you on your first medication, and probably about 50% of individuals will respond to that first medication. But if they have to start you on your second medication, only another 12% will probably respond to that second medication. But if you get to that third medication, only another 2% will respond. So there's usually always that 35% of individuals who's tried everything under the sun and they're still having breakthrough seizures. And that's when your neurologist will start thinking out of the box of other different treatment options for seizures. They'll look at brain surgery, and they'll also look at the vagus nerve stimulator. And for brain surgery, they're going to send you to the epilepsy monitoring unit, where they're going to take you off of all of your medications, because the purpose of being there is that they want to capture a seizure, because they really want to find out where that focal point is, where that seizure is actually occurring in your brain. And if they can find that focal point and the benefits outweigh the risk, then maybe you'll be a great candidate for brain surgery. And if not, a lot of times they will refer you for the vagus nerve stimulator. And the vagus nerve stimulator is a surgical procedure. It takes about an hour in the operating room, and the surgeon makes an incision right in the chest area, and that's where this little generator is placed. And then they make a small incision right in the crease of the neck, and that's where your vagus nerve is. And this lead has 3 little electrodes at the end, and they curl those little electrodes right around your nerve. So this generator will send a stimulation to your nerve, which will send a stimulation to your brain, which will hopefully abort a seizure, shorten a seizure, or shorten the post-ictal time after a seizure. So you have different treatment options that you can talk to your neurologist about. Again, medications, you can talk to them about the ketogenic diet or the modified Atkins diet or the vagus nerve stimulator or brain surgery.
I know the difficulties that the service members here at the Richmond VA, the problems they may encounter, especially after a traumatic brain injury. And we have a large number of patients in the Richmond VA who have suffered traumatic brain injury coming back from the recent deployments. Traumatic brain injury is seen relatively frequently in our polytrauma population. It is considered the signature injury of the Iraq and Afghan wars. One of the reasons we see so much traumatic brain injury is because the use of improvised explosive devices. There are a lot of reasons that people may have seizures while deployed, and some of it may be due to an electrolyte abnormality, in which case, if you correct it, they'll do fine. In general, though, for those patients who develop seizures while in the military, we evaluate them either at a larger medical center, such as would be seen in Germany, and then sent back to places such as the McGuire Veterans Administration Hospital, where we do further workup and decide what type of seizures they're having and what would be the appropriate medication. It pretty much ends your military career. And the real reason for that is because, especially in the austere environments, if you have a seizure, then you're going to tie up at least 2 other of your soldiers taking care of you. If you have a seizure while in the military, what they would do is transfer you from a job that would transfer you from an austere environment to a environment that, like an office environment. Then you'd have to go through a medical evaluation board, and then they would decide whether you could stay in or not.
The prevalence of epilepsy is highest among older adults, especially after age 65. In those older than 70, the incidence of epilepsy is nearly twice that of children. And in those aged 80 years and older, the disorder occurs 3 times more often than it does in the pediatric population. Among patients older than 75, 10% will experience a seizure and 3% will be diagnosed with epilepsy. Until recently, however, there has been very little information about epilepsy or seizures in older adults.
Keep all your doctors informed of your medications because there may be drug interactions with the anti-epilepsy medicine. Seniors may take longer to process and eliminate medicines, potentially causing medication levels in the blood to become too high. The anti-epilepsy medicine may have a stronger depressive influence and may cause agitation and loss of appetite. Make sure to exercise regularly and spend time with friends to overcome these symptoms.
Seniors break bones more easily, so carpeting helps if you have tonic-clonic seizures. Also, a person does not have to be removed from his or her wheelchair during a seizure. The wheelchair needs to be secured and a seatbelt loosely fastened to prevent the senior from falling. You can also make sure the wheelchair is padded to prevent further injuries to limbs.
Being aware of how epilepsy affects seniors will increase the quality of life in your golden years.
The Epilepsy Foundation of Virginia is here to provide assistance as you move into this new stage of your life so that you can still be productive, happy, and have a healthy life. You are not alone.